Welcome to the first class of the Mortimer Green test and discussion season. So this first class is open to all because we want people to understand how the system goes, how our classes are going to be scheduled. Our classes are going to be very interactive. There are going to be a couple of questions, 15 to 20 questions, which are going to be posted the day before in each session. And sometimes you might have more than one or two sessions. The sessions will go on for about 45 minutes to 1 hour. And you can stop me, ask me doubts, preferably at the end of the session. That's how it's structured to be. What we are going to be focusing on is the most important concepts, the kind of questions which are going to be asked for you in your exam. And what I can assure you is that over the past 2.5 years, when we've been conducting these test and discussion sessions, our students have found them to be extremely useful. Questions have come actually exactly from the test and discussions. And I will also use this platform to talk about how to generally prepare for MRCS Part A, where to read each topic, how to go about approaching your exam. So, how many of you are writing your exam in January? If you're writing, you can just put a thumbs up in the chat. I think a lot of people are writing an exam in January. So, how many of you here are post MBBS? So, you can type in MBBS, just MBBS. And I just want to understand how many of you have not entered into your surgical training. So I think we also have a couple of people in that sense. I think this is going to be a very interesting session. So I'm going to clear. I mean, if you're a surgery resident, then don't put as post MBBS. I know you're all, everyone has to pass MBBS to get into surgery, but yes. So I'll clear one big misconception. A lot of people believe that you cannot clear MRCS Part A if you just post MBBS. No, that's a misconception. The MRCS Part A is meant to be for court trainees in the UK, which means that most of them are just post their MBBS or basic medical training. Number two, you don't need to be a general surgery resident to have a significant advantage in your MRCS. Yes, there are certain aspects of it which will help you out. But what I personally found is that irrespective of what you are, whether you're post MBBS, whether you're an orthopedic surgeon, whether you're post MCH, I've had a lot of people say, I have had a 68-year-old gentleman, a very famous surgeon, who has not been in academic surgery for a very long time, passes MRCS Part A in the first attempt. We have had people just right out of MBBS do extremely well in their MRCS Part A. So the right way of approaching exams is very crucial. So the funda is very simple. Attend the test and discussions. Attend test and discussions help you structure your class or practice and what to read. Solve the MCQ bank on the Mortimer Green app at least thrice. If you're able to solve it twice, great. If you're able to solve it thrice, absolutely amazing. Make sure you solve at least 10 recalls every single day. There is a significant amount of recall. There are 8 recall sessions around 600 questions, just plain recalls. And we're going to be adding more recalls as well. If you're able to solve these recalls, I can assure you that you will get a mark of almost 85 to 90%. And you might think I'm joking, but I've had a lot of students who are able to follow this strategy and where to read. For most of your basic sciences part, in whichever areas where you're having a doubt, read from Raftery. Now, you might have read some book in anatomy for your PG preparation, whether it can be some PG preparation notes or anything. So, do you forget that completely? No. What you need to do is you need to solve the questions on the Mortimer Green app, go back to your notes and make a note of it in the notes and use that to revise your anatomy for MRCS Part A. So, for example, you've read anatomy from some other source. I'm talking only about anatomy. Physiology, you don't need to read at that level for which you read for your PG preparation. That sort of stuff is not, you don't need. I would say that go back to your old notes, make a note of what are the important points in MRCS Part A. As you're progressing through the sessions, I'll tell you what part of anatomy is very important and how to read anatomy. I particularly stress extremely high on anatomy with one reason. About 75 to 80 questions in your exam, out of 300 questions, 75 questions are directly going to be from anatomy. Anatomy, there is no conceptual thinking. It's you know it or you don't know it. It's a lot of facts. And it is the easiest way to get a good mark in your exam. Am I being very clear with this? This is something you'll have to remember. You cannot expect to do well if you are unprepared with anatomy. If you have to read only one subject, it's going to be anatomy, not surgery. Am I being very clear? So that is something you will have to remember. So let me start off with the session. And as time progresses, we will be discussing a lot more concepts. And for those of you who have already not enrolled, you can enroll. You can contact the Mortimer Green helpline. You can enroll in the session, and you can just put it out over here in a group as well. A 17-year-old boy, Matthew Bunnell, was riding his uncle's bike and got into a motor vehicle accident. He's brought unconscious to the emergency room where a fast scan showed a ruptured spleen. His BP is dropping rapidly and emergency splenectomy is proposed. Which of the following is the most appropriate action to be taken regarding consent for surgery? So 2-3 points. 17 years old. 1. Number 2, unconscious. 2. 3, BP is dropping rapidly. 4, emergency splenectomy. So what do you see and what do you want to do over here at this point of time? So Shrikar has told me E, proceed without consent. Hey guys, you'll have to answer. This is an interactive session. You can make mistakes. I'm not going to judge you based on this. So Lal sir has also told E. D. D. E. B. Contact social services to seek consent. So I'm going to start with what Aditya started. Contact social services to get consent. Now you'll have to understand the UK system. In UK, like in any civilized country, nobody works after 5 p.m. Like nobody should, unless it's an emergency. Now you're seeing this patient at evening 11 p.m. Do you think you'll be able to contact social services to seek consent? So, no. 17-year-old boy contacting the parents, that child may be living alone. Do you think it's right for us to contact this thing? C is obviously wrong. Treatment cannot be initiated as the patient is unable to consent. That obviously does not come over here. So most of you have said E and some of you have said D. Let's see what is the right answer. The right answer is consent by proxy. So the consent by proxy is a very unique system in the UK. So you'll have to understand how UK works. UK may, it's all public healthcare, which means that the government is funding the healthcare. You pay 6% of your taxes to the NHS, completely everyone pays, so that you are treated free of cost, which means that the state, which is the government, takes complete responsibility for your health, which means that consent is important, but somebody else will be taking your consent. And who is going to be the taking your consent over here? Here it is going to be the surgeons who are treating you. So this is an emergency situation where it is not possible to receive consent from parents or patient himself. Therefore, consent by proxy. Two independent doctors, one of whom is a consultant, may provide surgery, consent for surgery as it is in the best interest of the patient. This is a part of consent form 4. So you'll have to remember what are the consent forms 1, 2, 3, 4. Other 1, 2, 3 are not so important for you, but 4 is definitely important. So consent form 1 is you are undergoing a surgery. So for example, I am undergoing a inguinal hernia surgery. I agree to it. It is correct. My son is undergoing a surgery and I have to consent. It is consent form 2. Do remember this, please. Consent form 3 is patient or parental agreement to an investigation where consciousness is not impaired. Say, for example, I'm going to undergo a lipoma removal. Their consent form 3 occurs. It can be for my child or it can be for myself. Here, there is no likelihood of the patient going in for GA, no impairment of consciousness. So that is consent form 3. Consent form 4 is for patients who lack the capacity to consent to investigations or treatment. Do not make too many notes. I want you to understand the concept. These questions are also there in your question bank as well. But here I'm trying to explain certain concepts to you. So where will you use this consent form for? So now you tell me, Buddy Vinayak, don't smoke. Smoking is bad for your health. I look crazy. I don't understand. I'm in dementia or I'm unconscious. You can use consent form 4. Next, I am able to decipher the language. but I lack the mental capacity to understand. I have the mental capacity of a 5-year-old. I am suffering from some sort of deprivation of mental capacity. I am specially challenged. I'm differently abled, which means I cannot understand what you're trying to say. That is also consent form 4. Technically, I can understand smoking. He knows what is smoking is, but he doesn't understand what it does. Next thing, he is able to understand, but he is unable to use that information to take a valid decision. Now you tell me, when I don't smoke, it will spoil your health or you will get lung cancer. I say, yes, doctor, I want to get lung cancer. This is the greatest joy in the world. I want to die early, which means that I'm able to understand what you're saying. I'm able to understand the language. I'm able to understand the concept of death, but I am unable to use that decision information to make a valid decision. I'm talking stupidly, which means again you can use consent form 4. So in all these situations, the patient is having uremic encephalopathy. They can't comprehend. You can use it. Patient is having dementia. You can use it. Patient is mentally challenged. You can definitely use it. Or patient is behaving incomplete, is in a psychosis episode where he's talking like this. He's unable to use his information. He's able to weigh the information to take a good decision. You can use consent form 4. So coming to the 17 part. 17-year-old, child or adult? Guys, you'll have to answer. I'll stop the session if you're not going to answer. You guys are paid for it, so you'll have to make use of the money. You start thinking like that. You should think, how do I best exploit Vinayak to understand this concept? Adult, child, child, adult, child. Chalo, I'll tell you. So consent form 4 is usually for adults, right? Usually. So I'll tell you a simple concept. Technically, on paper, you can say that 16-year-old in Scotland is an adult. In UK, it is 18-year-old is an adult, but all that doesn't matter. There's really one thing that matters: Gillick competence. Gillick competence is when you think that a child has the ability to comprehend the information and take a decision on their own, they can actually consent for surgery themselves. But this is completely ununderstandable in India. I am in pediatric surgery. I deal with children on a daily basis. In India, even 15-year-olds, they cannot do anything without the consent of their parents, but it's very different in the UK. So who was Victoria Gillick, whose name became a law? So she opposed 15-year-old girls getting abortion pills or contraceptive pills. She wanted to regulate their uterus. She was a highly religious person, and she felt that they don't have the ability to take decisions. The court overruled the House of Lords. The court said that no, 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 that's bullshit. Children, if they are sensible, they have the right to regulate their own uterus. They have their own regulate birth control. They have these rights, and her protest was overturned. And uh, unfortunately, her name itself was attached to this thing. I mean, she must have felt pretty sad. They call it Gillick competence, but she kind of opposed the entire idea of Gillick competence. So she was a Victoria Gillick. She was a religious activist who opposed the idea that children should be given rights over their own bodies. But what age do you consider a child to be Gillick competent? I want all of you guys to answer. Is it 7, 8, 9, 10, 11, 12, 13? Like, is it some sort of lucky number? So the answer is 15, 14, 12. I think we got the entire spectrum: 12, 13, 14, about 12. So the answer is there's no one. There is no age at all. You feel that a 10-year-old girl is very sensible. I usually find girls pretty much more sensible than boys, even at a younger age. You feel that a 10-year-old girl is sensible. She can take her own decision. She can be certified Gillick competent by the treating team of surgeons, and they can allow her to take consent on their own. Usually, we don't do it for 7-year-old, 8-year-old. Usually, it is over 10 to 12 years old. But there is no fixed age when you start calling a person as Gillick competent. Am I making it clear? Okay, so now let's go to the next part of the thing. Ralph Mosley is found under a pile of rubble at a building site. His right thigh is crushed. The surgeon feels his limb is unsalvageable. So 2 points. 29-year-old, right thigh crushed, limb unsalvageable. He's disoriented and confused. His urine tests positive for myoglobin and is dark looking. His wife states that since his brother lost his leg in Iraq, the patient has said several times that he would rather go through anything than lose a leg. What is the correct management for this patient? So let me see how many people are able to get the answer right. I have A, B, C, D over here. Nobody's answering. Like I told you, we will shut down the discussion if you guys don't answer. I can be pretty brutal. You can ask your seniors who have taken this course. So A is manage Ralph in the ITU. You can attempt. I'm not going to judge you. Oh, okay. So the answer actually came out. So ask the patient to speak to the patient's brother. That man, poor man, he's lost his leg in Iraq. You want to ask him? Or C, B, or C. Okay, I think there's a confusion in this thing. It's A, B, C, D, E. It's not A, B. Manage Ralph using ABC principle, call the on-call legal team. D, Ralph principle, book the patient for a below knee amputation with a consent form 4. Or C, book the patient for a above knee amputation. So the last option is option E, which is book the patient for an above knee amputation after taking consent. So the answer is E. So you will have to, following discussion with the patient's wife, book the patient for a above knee amputation. So it's not D. I think you are not able to see the E option because the screen was not very clear. But the answer is E. Why should you not? All of you have written D. The answer is wrong because if the right thigh is crushed, you will have to go in for a above knee amputation. You cannot do a below knee amputation when the right thigh is crushed. Like I said before, he's 29-year-old adult, no problem. He's disoriented, confused. He's having encephalopathy, uremic encephalopathy, because he's already having hemoglobinuria, renal failure, sepsis. So he would need a high amputation, a right thigh. And you can and you should discuss with the patient's wife, but you don't need to get permission because the only person who will be giving permission, the only person who will be signing consent is the consultant who will be signing consent form for adults who lack capacity. And here, Ralph has lost capacity because he is confused and disoriented. Are there any doubts? At this point of time, I'm going to stop and I want you to type out your doubts in the chat and ask me. If you have any doubts, you can ask me right away. Nobody has any doubts? So like I told, I'm going to re-emphasize again. Here again, it's consent form 4. Okay. You go on above knee amputation. Yes, Aditi, there is absolutely no role of wife's consent. In the UK, every individual is individual. And if he cannot take a consent, there is no role for wife's consent. But yes, you talk to the wife to understand what his opinions could be and to understand the family's opinions. So this is a very important part in MRCS Part B, where you'll be actually dealing with these kind of situations with actors. So if the patient's wife says no to the amputation, that's it. No. You still go ahead and do the amputation. Who will certify that the patient is not in his full capacity to give consent? The consultants who are signing the consent form 4. The patient wife says no to the amputation. Even then, she has no role because here the amputation is the only way to save the patient's life. So you use consent form 4 and you use your consent, decision making pass to book the patient for a surgery. What is the difference between consent form 1 and 3? 3, Kritika has asked me what is the difference between consent form 1 and 3. 3 is for patients who are undergoing procedures which do not require loss of consciousness, which do not require GA. For example, a lipoma removal, a suture removal, those kind of things is 3. And also negative consent. If patient is competent and patient is saying no, we will still amputate, no, then you cannot. If the patient is completely within his senses and he refuses surgery, for example, a Jehovah's Witness who is refusing blood transfusion, you will not do blood transfusion because the patient understands the risk and is still refusing surgery. So in that situation, you cannot intervene. You cannot use consent form 4. You cannot force the patient to undergo surgery because that's his life. But the wife does not have power over this thing. When it comes to children, a 7-year-old is going to undergo surgery Father says religious beliefs, I cannot allow blood transfusion. There you can use, you don't call it consent form 4, but it's kind of like consent form 4. You use Children's Act 2005 and book the child for surgery and give blood transfusion because the father is being illogical. He can play with his life, but he cannot play with his child's life. It's a very great concept, to be honest. You have control over your life, others don't have control over your life. But if someone has to take a decision, it will be the sensible doctors who are taking a decision. You can ask a lot of questions, there are a lot of ethical queries, but that's a debate. After you pass your MRCS Part A, we'll sit down when we are partying together. We will discuss whether this is right or wrong. But here you will have to remember what is the right way of doing these things. I hope you're all getting it. Okay. Okay. So we'll go to the next question. So here again, this is a concept of consent over here. So Gregory King is a 55-year-old man who's been brought to your emergency room by the paramedics, and he's accompanied by a policeman. The policeman tells you that Gregory is a bus driver who has just driven into a tree, injuring himself and two passengers. Now, this man has a laceration to the head and appears confused and disoriented. The policeman asks you to obtain a blood sample to test the blood alcohol concentration, but you are seeing that the Gregory is not capable of giving consent for this. Why? Because he is confused and disoriented. Now, what is the most appropriate action in these circumstances? So just forget the options A, B, C, D, E. There's no F. The second row is right. So take a blood sample. So let's see how many of you are answering it. Nobody answers to me in direct message, buddy. You have to answer. You have to put out the answers in actual the forum. Take a blood sample now. Wait till Gregory can give consent before testing for alcohol. Take a blood sample, but wait till Gregory is regardless of his willingness. Take a blood sample and immediately give it for analysis as this is a medico-legal case. Now, this seems to be the most sensible. Okay, Gaurav, I'm sorry. He's asked for time to read. D, take consent from Gregory's emergency contact and draw the sample for immediate analysis. So, Gaurav, you will have to answer this question because you've been given time to read as well. Or inform the policeman that you can draw the sample only when Gregory is able to consent for it. We had a couple of A's. Gaurav said D. Avyad C. To be honest, from a very logical point of view, C seems to be sensible. But let's see if the answer is C. Unfortunately, the answer is not C, it is A. Now, this might be very confusing to you, but I'll explain this in detail for you. So you'll have to take the sample and wait till Gregory can give consent for blood alcohol testing. So this is according to the Police Reform Act. Here, you don't need consent from unconscious or incapacitated drivers to take sample, but you cannot give the sample for testing. You cannot test it till the patient regains competence and provides consent. But a competent patient who refuses to allow his sample to be tested might be liable for prosecution. So now you might ask me, why do we need to, confuse all of us with all this sort of stuff? We could have anyway given it for testing, because what is the point? So if he has to give consent, but if he refuses consent, he can be liable for prosecution. You might tell me, what is the need for this? But the fact is, this is how the law is, and this is logical or illogical. You will have to remember this. And this is according to the Police Reform Act. And you will have to remember this. It is the clinician's duty to justice. It recognizes the clinician's duty to justice. But Gregory King needs to be tested. He needs to take the sample, but he cannot be tested for the alcohol concentration. Do you get the point? Yes or no? Let's go to option B. Yeah. Regardless of his willingness. See, you don't again, you need the consent for testing. So regardless of his willingness is not the right option. So logically, yes, you can say that option B is similar to option A, but it is not. Okay, so it really is actually different from option A because you actually need his consent. So this is a little confusing. So I'll explain this a little more easily to you. Drunken driver, you can take the sample, but you cannot test it for blood alcohol concentration. Understood? If the patient dies somehow due to any reason, at that point of time, the court will decide whether he needs to be tested or not you. So that responsibility becomes a court. Okay. Okay. Let's go to the next question. Consenting a patient for invasive intervention. Am I okay? Am I being okay? Are you able to understand these concepts? These are all slightly tough concepts to understand, and that's why we are doing these sessions. If you're enjoying the session, I want all of you to give me a small thumbs up so that I can know that I'm proceeding at the right pace. But you can always feel free to stop me at any point of time. Okay. Okay. I got a lot of thumbs up, so I think I'll proceed at this particular pace. Okay. While consenting a patient for invasive intervention, which of the following is not information that must be provided for the consent to be valid? I'm going to give you time to read the options. Risk benefit, you need to tell. You need to tell explanation purpose. You need to tell whether the treatment is experimental and success rates. Do we need to tell other options for management? Success rates of the doctor who will perform in comparison to national listing. So yes, all of you got it right. See, you're all getting the flow. First three questions, most of you got it wrong. Now you're all getting it right. So I'm sure you're all doing well. So at the end of the session, you all are going to be experts in medical legal aspects of UK health, especially related to surgery, and you're going to do well. So what are the things you're going to tell? So now comes the easy concepts. I've cleared a lot of these difficult concepts. So you're going to tell about the diagnosis. You're going to be telling about options for treatment and option not to treat. What happens if you don't treat? Options for further investigation. Purpose. Why are you doing a particular investigation or treatment? And likely benefits and probabilities of success. Advice about whether a proposed treatment is experimental. Plan to monitor. Name of the doctor who will have ultimate overall responsibility, and where appropriate, names of the senior members of his or her team. So you guys will escape. You're all junior members as of now. One day you will become senior members and take responsibility. A reminder that all patients have a right to take a second opinion, and they can change their minds about a decision any point of time. Okay. Patient should be informed about surgeon's own complications. You can say, okay, this is my complication rate. You don't need to give a comparative figure against the national rate of complications. Why? Because some surgeons will be doing more complex cases. Some surgeons will not be taking up complex cases. So that is not information which is necessary. This is an actual question which has come up in the exam. So I want you guys to remember this. Okay. So again, coming back to consent, why in obtaining a consent, which of the following is not true? Provision of translators. If patient doesn't understand the language, any member of the surgical team can take consent. Enough time must be given to arrive. Consent should be taken in a quiet room. All of the above. This you should get it right, guys. D's, couple of D's, mostly B's, some D. Consent should be taken in a quiet room. So yes, option D is actually true. It's not the answer. So answer is option B. Like I told you, why do we talk about the senior most members of the team? Because they take ultimate responsibility. So either the consultant or someone senior should be taking. Only if they are not available, you others can take. And say for the example, emergency surgery, but the consultant is stuck in some other emergency. Only then any member can take consent. Otherwise, only the senior most person who is going to take ultimate responsibility takes consent. So the answer is option B. Okay. Translators are a must. and UK, all the big hospitals have translators in most languages, including many of the Indian, Pakistani, Bangladeshi languages as well. Patient or the attenders must be given enough time to decide, and it should be done in a quiet venue for sure. There's no question regarding that. So let's go to the next question. We'll go a little fast over here because this is going to be slightly easy. So, when shall you not breach patient confidentiality? I'm going to give you enough time for you to read it. When you want to discuss this information with a specialist, or next of kin, social worker, police, local authority, or discussing the patient history with medical student at rounds. Read it very carefully. I want all of you to answer this question. Aditi is done. Aditya has answered. What is the only situation where you're not supposed to discuss anything with the attenders? Or with you're not supposed to make the not attenders with the you're not supposed to breach patient confidentiality. Very few of you have got it right. So let's look at the answer. The answer is medical students. So, option one. When you're discussing the case with, say, a medical oncologist, patient has renal failure while giving a chemotherapeutic drug, you'll have to discuss with the nephrologist. So, definitely allowed to discuss. You are not supposed to disclose confidential information to the next of kin, usually, especially when the patient is awake, having the sick, because until you tell the patient that, okay, I'll get their permission, you're not supposed to. But when the patient is unable to take any decision, when patient is terminally ill in the ventilator, you can discuss it with the next of kin. Next of kin only, not any attendant. Police or social worker, when the patient is a threat to themselves or not, they are about to tell you that they are going to what do you call the plant a bomb somewhere or have some planted some anthrax somewhere, you will definitely have to tell. Disclosing the local authority when a highly communicable disease is over suspected, you definitely will have to breach patient confidentiality. Where you're not allowed to do is you cannot give patients history and private information with medical students at rounds. Are you able to get it? Medical students can be given this information only if the patient has given explicit consent. Notifiable diseases, you can talk about the patient generally without disclosing details or without showing the patient in a ward rounds where all the identifiers are removed, that's different. But private information about the patient or showing the patient's genitalia, that can never be done without the patient's consent. Get the point? Okay. Simple question. Long stem, but I'm not going to talk about it. Brainstem testing, who is allowed to do? Okay. Guys, you'll have to answer. Shrikar, I must commend you because you're always among the first to answer, but others have to answer. See, you guys are getting smart. So, one thing, surgeons love to operate. A liver transplant surgeon loves to operate quite a lot. They're fucking trained for so many years. So, they should definitely never be a part of the team. So, two doctors, one of whom is a consultant, both 5 years GMC registration, neither of whom are a member of the transplant team. This is the right answer. But no question. This question will invariably come in your exam. I can assure you this. This will invariably come in your exam. This came in the exam which I wrote. This came in the exam which other faculty of MRCS Mortimer Green also wrote. This is a very standard question, one of the most standard questions. Memorize this, remember this. How you're going to do that, I don't know, but you will have to remember this. Okay. This question, I don't expect any of you to get the right answer because either you know it or you don't know it. So I'm not even going to ask you to type it out over there. Which of the following is not one of the 7 pillars of clinical governance? 1995, there was a major crisis in UK. Certain hospitals reported huge amounts of pediatric cardiac deaths post cardiac surgery. So they started investigating and seeing what is the reason why all this is happening. And the inquiry's result, they came out with 7 pillars of clinical governance. So which of this is not a part of clinical governance? The answer is cost control, because the 7 pillars are clinical audit, clinical effectiveness, risk management, use of information, staffing and staff management, which is education and training, same thing, and education and training, and client experience or involvement. Basically, all these things are very important. You will have to remember these 7 pillars. There's no other option. You'll have to memorize this and get on with this. Okay. So I'm not going to waste too much time, but I've put this question so that you know that this is a oft asked question. This is a question which is quite often asked. Now let's come to some interesting topics. 9-month-old child to the ER. Inconsistent history. Which injury most raises suspicion of non-accidental injury? Non-accidental injury. So I'm going to ask you a different. Non-accidental injury is suspicious injury. Okay. So I'm going to ask you a question. Have you played cricket or football in a concrete in your school basketball court? Have you ever played generally? Or when you're growing up, did your parents tell you that you used to walk on your knees? Answer me. You can answer the later this thing. Very few of you have got the right answer. So answer me. Have you all played football or hockey in a concrete court in your school basketball court? Yes, right. So when we were kids, me and my brother is also a surgeon. We were kids, my younger brother. Like two brothers usually are, pretty naughty guys. Most of the times our mothers had to drag us by our collars in to the home because we always used to keep playing, wouldn't do homework on time. Not really good kids at home. But there's only one constant stuff which was there. There was bruising in the knees always. So most of these boys who grew up in the 90s before our parents couldn't afford video games or PlayStations at that point of time. So most of the time they were left playing outside. So bruising over knees was such a common thing. So all of you have answered E. Have to think. Bruising over knees is very common. And in a 9-month-old child also, when she's starting to walk or this thing, you will see that they are trying to walk on their knees. So what type of deformity? So the correct answer is option C, femoral shaft fracture. I'll tell you why. Say you're holding a child. This is a child. This is my iPad is a child. I'm staring at the child. So I'm facing the child like this. And I'm holding it. And when I'm holding it, my 4 fingers are pressing on it. This is not something you should be doing with children. And this is something very pathetic. As a pediatric surgeon, I've seen it and it pains our heart. But when a person is crushing a child on the torso, their 4 fingers are crushing the posterior rib. Anterior rib fractures are not very common. Posterior rib fractures, ribs are very flexible. So when they are injured, they usually don't get injured in children by accident. Normal. When someone is actually injuring, that's when it causes. So posterior rib fractures, it's not anterior rib fractures. Clubfoot is a deformity. Hip dislocation, congenital dislocation of hip, very common. Bruising over both knees, I told you. Long bone fracture in a child who has not yet started walking is very classical of non-accidental injury, child abuse. So remember option C. So long bone fracture. So what are they just saying? Multiple fractures in various stages of healing. Corner fractures at the edges because when the bone is being pulled. Posterior rib fractures, like I told you. Transphysial separation of the distal humerus. And they twist their arms like this. Transphysial separation of the distal humerus. That is very characteristic of child abuse. And these children should be admitted to the hospital, and appropriate child protection professionals, CPS, should be called, and you should intervene. Okay. Signs of child abuse: long bone fracture, single fracture with multiple bruises, multiple fractures in various stages of healing, corner fractures, posterior rib fractures, new periostal bone formation, skull fractures in association with intracranial injury, transfacial separation of distal humerus. All these are extremely characteristic of child abuse. Let's also talk about bad burns. You will have to remember this. So cigarette burns, if you've seen this, it's very pathetic to even look at it. We've seen a couple of those children, and it's very, very sad to see that. Branding injuries. You take a branded fork, in Tamil, they call it sudu vekirathu. I don't know what they call it in Hindi. That's something which I don't know, but it's a very common form of child abuse in India as well. So that's something you should remember. When you immerse a child into hot water, there is a classical distribution, which I'll show it to you. So are you able to see the zebra stripe over there? The zebra stripe is very characteristic because when you're holding the child like this, your fingers are very resistant to heat. The child is extremely sensitive, so it causes those classical zebra stripe. When a child is being immersed, the bottom of the buttocks, which touches the tub bottom, is protected from the heat. So the other part. So this is classical donut type sparing. So this is glove and stocking distribution, along with donut type sparing or zebra stripe. This is very classical of bad burns. Along with, these are the cigarette burns. You can see that cigarette burns, vellus hairs, singed vellus hairs. Vellus hairs are that mild, small hairs which you would see in children. Singeing is like that small burns which you see in those hairs. Okay. So let's come to one more question. LPA, lasting power of attorney. 18-year-old Alzheimer's, ulcerated squamous cell carcinoma, not an emergency. Son shows you that he has a lasting power of attorney and will be able to consent to the treatment on her behalf. Which of the statements regarding an LPA and consent is true? I'll give you time to read the answer. Okay. Let's see what the right answer is. Here you know the answer or not. So we'll get to what LPA is. Then we'll come back to the options. LPA is a legal document made by someone called as a donor in anticipation of losing mental capacity. So say I'm suffering from multiple sclerosis. I know that someday I'm going to lose my mental capacity. So I write a document and I make someone my attorney. It can be my friend, it can be my wife, my partner, my colleagues, anyone whom I trust with my life to take good decision. It can be one or two, and the terms can be different. These are people who I trust will take a decision based on my best interest. Here, an attorney does not mean a lawyer. An attorney is a person who is allowed to execute it. So an attorney might be my father, who is a doctor, or my mother, who is a teacher. It need not be an attorney actually. So the attorney term can be confusing. Okay. There are two types of LPAs. One is a health and family welfare LPA and a financial LPA. Okay, an LPA can be made only by a person above 18 years, but at the time of creating, he or she should have full mental capacity. Okay, so there's a difference between financial LPA and health and family welfare LPA, health and welfare LPA. Health and welfare LPA comes into effect only when the person loses his mental capacity, but financial LPA is to allow the person to take financial decisions. They can invest in stocks or whatever they want on your behalf. Comes into movement once you sign it. So once you register it, you can do it. Okay. So it's a legal document. 18 years old above can sign it, create it. At the time of signing, they should have good mental capacity and should be registered to the OPG, Office of Public Guardian. Look at the options. So option A is definitely right. Option B, it doesn't come into effect once it is registered. It comes into effect only when the person loses his mental capacity. Option C, wrong, because 16 now, it's 18. Option D, they say cannot be made by anyone above 18. Absolutely wrong. Yeah, so let's look at the last option. Very important. If there is more than one attorney registered, they must both give consent. No, it doesn't work like that. It depends on the terms of the LPA. Now, the person should write, say, for example, I appoint two of my friends and I write, either one can decide, then only one consent is enough. If I write, no, both of them should decide, then both of them should decide. It depends on the terms of the LPA. Am I being clear, or do you have any doubts? Okay, perfect. Yeah, okay. Huh. So you walked into your doctor's room late in the night, 2 a.m. Meher, your senior registrar, is smoking cannabis peacefully while on call. She even has a pager while she drags the fumes into her lung. She says she's had quite a stressful leave and has only one joint to help her relax. What would you do? Quiet night, tell her that this is the last time and ask her to carry on, ask for assurance. Or ask her to arrange for someone else and nothing more will be said. See, ask to discuss matter to the consultant and supervisor in the morning and carry on. Ask her to phone her consultant to self report immediately or phone the GMC line for on call advice. Quickly. About 1.5 years ago, there was one person, he said option F, he typed, yes, buddy, there's only 5 options in your MRCS Part A exam. Asked what is option F, he said, I would ask for one more joint because I'm also stressed. That's not the right answer at all. Most of you are getting it right. So the answer is option D. You cannot wait till morning, Dr. Ashutosh. Okay. So very important concept. I'll explain to you in detail. Okay. So she should be encouraged. You should tell her that you self-report. You call your consultant and tell. If she doesn't do it, then you should. It is a consultant responsibility, not your responsibility. He should step down as a registrar. He should become the registrar and deal with it immediately. He should come from the his home. He should become the registrar. And if he's unable to find one more registrar, but you cannot forget this incident. You cannot say, okay, I won't tell anyone about it. You should escalate it. And after the situation is resolving, next morning, you should report it to both the trust and GMC. Like I told you, nobody in the UK works after 5 p.m. Even GMC will not pick your call after 5 p.m. because it's nothing they do is an emergency. So once the situation is made safe, trust will face both trust and GMC. Register will face both trust and GMC disciplinary proceedings in due course. So mayor is screwed for sure. That's a different thing. But you make sure that you are not screwed, because if you don't report, then you can be taken for task. Okay. Now you also don't go and ask her for one joint and smoke along with her. Okay. Like I told you, this question I have already discussed with you. Pneumothorax, grade for shock. Father states he would rather see his child die than receive a blood transfusion. What is the correct management of this child? Quickly, I want your answers. Last two you can't do on call. There is actually an Yova's Witness Coordination Committee license cell, but that's not something which you can do at late in the night. Elders of the community, you can't sing it. Answer is option B, like most of you have said. Like I told you, father can refuse consent for himself, but for the child, you will have to transfuse while you result. So you will have to manage the child as you would manage anyone else. So this is something which you have covered in the first part of our class, and you will have to remember. And this is according to Children's Act 2005. Okay. So a special gift, a chocolate for the person who answers, who says, and which show that is. It's one of my favorite shows. So in a child with younger than 11, 12 years or older children that lack capacity, medical treatment cannot be performed without consent unless for life-saving treatment. Elective treatment, you need their consent. So yeah, it's Brooklyn 999. And who is the character? Okay. Yeah, you're all getting it right. Okay. Okay. You are a young surgeon from India who's just joined as a registrar. You're super interested in teaching students for the exams because you believe teaching makes you a better doctor. Yeah, Captain Holt, Shrikar, you got it right. Okay. So which of the following statements is correct regarding teaching and training in NHS? I'm not going to ask you to answer this question. I will answer this for yourself. So, okay. So option C is right. Evidence of teaching is important and forms a formal part of the appraisal process. I will come back to the question again, but I'll explain to you what is the concept. So teaching is a very, very important part of your duty and it's this thing. So if you want to become an educational supervisor, you will have to have passed the educational supervisor program or something similar. Okay. So only who have done these educational supervisor can become clinical supervisors or become like professors or all that sort of stuff. The time duration after becoming a consultant is not relevant. But anyone who wants to teach, say I go to UK next month and I want to teach someone something, I'm allowed to teach, but I cannot judge them. I cannot become a supervisor. Okay. And workplace assessments can be completed by middle grade doctors and consultants. You don't need to be a consultant to do this. Assessment, you don't need to be a junior doctor, but you can be a medium grade doctor. So coming back to this thing, which of the statement is correct? Any person who has been in this post for more than 3 years can be a educated supervisor. No. We have seen that anyone can be 5 years. No. Anyone can be a clinical or an educational supervisor. Evidence of teaching is important and forms a formal part of appraisal process. Yes, that is right. Only recognized teachers can teach in NHS. No. Anybody who wants to teach can teach in NHS. Workplace based assessments can only be undertaken by consultants. No. Your assessments can be done by middle grade doctors as well. You don't need to remember too much of this, but you need to remember that anyone who wants to teach can teach. Number one. And to become a supervisor, the time after becoming a consultant doesn't matter. But you'll have to be a consultant to become a supervisor. Okay. Okay. So answer this question, please. You are preparing for your appraisal. Now I'll tell you what an appraisal and revalidation means. Which of the following statements is most true regarding appraisal? Read the answers. Try to see if you're able to answer or understand. And if you don't know, I'll always there to help you out with your doubts over here. Let's see the answer. Okay. A lot of you have gotten the answer right. So the answer is option C. Let's kind of go back and see what appraisal and revalidation means. Okay. So let's come back to understand and then go back to the answer. Okay. So appraisal is a annual meeting taken between a doctor and a colleague who is trained as an appraiser. Appraiser need not be a consultant. Anyone who undergoes training to become an appraiser can become an appraiser. Appraiser is basically like a feedback system where you try to see where you are growing. Are you doing things the right way? So there are three stages. One is the input, where doctors nature work, you say I have got to attend these conferences, I have done these workshop, I have trained well, I have done this much research, I have done this much audit. Then there's a confidential appraisal discussion between the appraiser and the doctor. And then there's an output, input, discussion, output. Output is the doctor's personal developmental plan and summary of the appraiser's discussion. They tell you whether you are fit to be a doctor or not. Appraiser can be from a varied this thing. It can be a GP, it can be a specialist doctor, it can be a consultant, it can be anyone. Okay. And client, colleague, and patient feedback are also used as supporting evidence for appraisal for revalidation. Both are equally relevant. Appraisal happens every year, one. But every 5 years, something called as a revalidation happens. So the feedback is a 360-degree feedback, which comes from every direction. 360-degree feedback means it comes from consultant, it comes from your juniors, it comes from your seniors, it comes from your colleagues, it comes from your patient, and this is a part of revalidation. But it need not. It can be used for in appraisals, but it is not necessary for appraisal. It is essential for revalidation. Okay, revalidation is every 5 years they check whether they can, their license can be retained. It is just to assure the public that okay, these people are valid. Okay. So revalidation, look at the options. A, every 3 years for revalidation, every 6 years, no, it's every appraisal 1 year, revalidation 5 years. Feedback from colleagues has lower weighting, no, if it's all equal. Feedback from patient, colleague, everything. Your appraisal can be carried out by a non-consultant grade doctor. Yes, that is true. It can be carried out by a non-consultant doctor. Register 5 years, it doesn't matter. 360-degree feedback is an essential part of your appraisal. No, it's an essential part of your revalidation. Okay. So option C is the right option. So we are ending this session over here. I have covered the most difficult concepts in medical legal aspects of health, UK health over here. But you will have to solve and go back to the questions as well, solve them, get back to me with your doubts. You can put the doubts in the group. For those of you who are not enrolled, there's a separate group. When you enroll, you will become a part of that group also, where you can ask me questions and doubts and everything. And I'm more than willing to go through the process of clearing exam with you. I wish you all the best. We have trained more than 1,000 students through the MRCS process successfully, and I'm sure you're going to be one of them. Thank you so much, guys. If you have any doubt, you can just put it out in the group. I'll be more than willing to answer. If you have any more doubts, I'll just wait for 2 more minutes. We'll be telling you the topics as well. Sometimes some of our consultants are in the UK and we might schedule a session a little earlier or before, but you don't need to worry too much about that. Okay. I hope the session was useful. I really hope that you guys do well in your exam. Thank you so much, guys.